very warm welcome to the LSE. Very nice to see you here. It shows a lot of commitment, despite the tube strike and the rain. You're here with us, so thank you so much for that. My name is Hussein Naji. I'm one of the faculty members in the Department of Health Policy, and I also direct the Pharmaceutical Policy Lab, also at the LSE. Before we begin this evening's event, I just have a few housekeeping notes. We are filming tonight's session, and the recording will be made available on our YouTube channel in a few weeks' time. We'll take questions at the end, and we have a microphone that will come to you, so please raise your hand and wait before you speak and ask your question so that everyone can hear it, as well as those watching the recording can hear your question as well. We're not expecting a fire alarm, so if there is one, it's real, and we will just meet outside. If you're posting on social media, please use the hashtag LSE Health. Because tonight's evening is part of LSE Health's 30th year anniversary. LSE Health is one of the largest research centers here at the LSE, and it's sponsoring tonight's event. So we're very thankful for that. So, on to tonight's main event. We're here to launch this fantastic new book, Beyond Belief: How Evidence Shows What Really Works, by Helen Pearson. If you haven't purchased a copy already, you'll have a chance to do so at the end. And Helen will be signing copies as well, I think. Great. Our speaker is Helen Pearson. She's an award-winning science journalist, editor, author, and communicator. She has been a journalist and editor for Nature, of course, the world-leading peer-reviewed journal for science. She has several awards. She was named European Science Journalist of the Year in 2025. She was the Editor of the Year at the Association of British Science Writers Awards in 2022. And she's also an honorary professor of practice at UCL, where she teaches science writing. We're also joined by our wonderful discussant, Dr. Dev Cohen. Dev is a medically trained, award-winning journalist and broadcaster. She has broken several major stories over her career at the BMJ, the British Medical Journal, the BBC, the ITV, and many other places. And we're really fortunate to count her as one of our colleagues at the LSE as a senior visiting fellow. And she published her book, Bad Influence, earlier this year. So what we'll do is Helen is going to give a very brief overview of her book for about 10 or so minutes, and then we'll do a Q&A, and then we'll open it up to the audience questions. So over to you, Helen. Thank you so much again for doing this.
Well, thank you everybody for coming this evening. Again, as Hussein said, for battling through the rain and the tube strike. So it's a real pleasure to be here. And I want to start by saying that probably some of you in the audience are far more expert at research and evidence than me. But what I can try to do is offer a perspective today on evidence as a science journalist, an author, and a storyteller. I've interviewed over 200 people about evidence in various fields over the last 5 years when I've been reporting my book. And I'll just try and give you a taste of that story and just a few of the key lessons that I've learned along the way. So first of all, let me explain why I decided to write a book about evidence. When I can make this work? No, it's going to be that one. There we go. So a few years back, I met and interviewed this man who is Ian Chalmers. Maybe some of you have met him. I learned his story, and that kind of introduced me to the modern history of the evidence movement. Now, in the early 1960s and 70s, Ian was a young doctor working in obstetrics and gynecology in the UK. But he noticed something odd, that when different doctors treated women with the same condition, they would often give out very different advice. So some doctors felt strongly that bed rest was really important. Some doctors thought that women shouldn't eat or drink during labour, and other doctors thought no such thing. And the disagreements were so fierce that Ian once said to me that when he was called in the night to treat a woman, his first question would be, "What's wrong?" And the second question would be, "Which doctor is treating her?" So in practice, what generally happened was that everyone followed the advice of the most senior doctor in the room, which is today sometimes called eminence-based medicine. Now, Chalmers was kind of puzzled by this because he didn't know which doctor was right or which treatment was most effective. And then he came across this. which is a 1972 book called Effectiveness and Efficiency by Archie Cochrane. Perhaps his name is familiar to some of you. And this book argues that the only rational way to decide whether one treatment is more effective than another is to use empirical evidence from observation or careful experiments. And he also argued that the best and most unbiased form of evidence comes from randomised controlled trials, in which people are randomly assigned to groups, one receives the treatment, one doesn't, and then we see if the treatment group improves more than the control group. So it's a kind of simple but very powerful method in science. Now, reading this book was a revelation for Ian. He was a qualified doctor, but he'd never come across randomised controlled trials before this point. And he was inspired to go on and do two pioneering things. So the first was he spent about 10 years hunting down all of the clinical trials that tested treatments in pregnancy and childbirth. And then he did something really important. He combined similar studies together, so synthesized the evidence using the technique of systematic reviews. And synthesizing evidence like this is hugely important in science, as I'm sure many of you know, because individual studies risk being misleading or wrong, but synthesizing them reveals what the body of evidence says as a whole, so we can extract a signal from the noise. So doing this revealed some shocking results, which was many routine practices were not supported by evidence or were actually doing harm. So, for example, shaving women's pubic hair during labour or conducting episiotomies. So countless women had been subjected to these degrading and highly invasive practices just because doctors assumed they were the right thing to do. And his work helped bring an end to some of them. Now, inspired by this, Ian went on to try and synthesize the evidence on effective practices across all fields of medicine, in diabetes and cancer and so on. And this was the idea behind the Cochrane collaboration, which Chalmers and others established in 1993. And today, the Cochrane collaboration is known for conducting gold standard, high-quality systematic reviews in medicine, and these are used to guide doctors' decisions. And this shows the Cochrane collaboration logo, along with two pictures of people who were so inspired by its mission and by evidence that they actually had the logo tattooed on their arms. Okay, so this was one really important part of moving medicine from eminence to evidence. But there was another important part of the story, which involves this person, David Sackett, who was working on the other side of the world. And this slide shows him with something called the evidence cart, which he and his team built so that they could actually access evidence on hospital wards before everyone had Wi-Fi and phones. So Sackett, like Chalmers, was frustrated with this eminence-based medicine approach, and he moved to McMaster Medical School in Ontario, Canada in the late 1960s. And this school became very influential for developing a new way of teaching medicine to students by solving problems using research, using evidence. And this evolved into evidence-based medicine. And that term was only introduced in the medical literature in 1991, so very recently, and it just means using the best available evidence to guide the care of patients. Now, evidence-based medicine was quite controversial and criticised when it was introduced, and that's because senior doctors didn't like being told that their way of working was wrong. But even so, it quickly spread around the world and has become the predominant way in which Western medicine is practiced. And today, almost anyone who's visited a doctor has benefited from evidence-based medicine, and yet few people outside academia and medicine have heard of it or realised that it's such a recent phenomenon, which is a big reason I wanted to write the book. So meeting Ian was really kind of illuminating and learning all this history. And soon I was interviewing people who were passionate about evidence in fascinating disciplines that I'd never explored before as a journalist. And I learned that evidence-based medicine is part of a bigger movement, which has been called an evidence revolution. And in the book, I look at how evidence has been embraced to various extents across different fields, so how it's used to tackle poverty, in policing, conservation, management, education, policy, and in parenting. And much of the current debate focuses on sort of rejection of science and evidence at the moment, and I really wanted to show this kind of counter-narrative, this kind of quiet, decades-long process by which evidence has been becoming quietly ingrained into our lives. Now, one thing I saw as I looked across all these different fields was this kind of shared timeline by which they were waking up to evidence, something I've called the evidence zeitgeist on this slide. And I mapped a few of them here. So in green is roughly when these terms were being introduced. So in 1991, evidence-based medicine, 1996, evidence-based education, 98, policing, 2004, evidence-based conservation, evidence-based management around 2005. And then on the bottom, in blue, I just put a couple of time points kind of representing the growing kind of wider political interest in using evidence to support policy, which is sometimes called the What Works movement. So we had Tony Blair and New Labour talking about what counts as what works in 1997, Obama talking about it in his inauguration speech in 2009. And I don't want to suggest it was confined to this time. The evidence revolution predates this, and of course it goes on today. But why was there this kind of big flurry of interest around this time? I think that part of it, at least, is the diffusion of ideas and methods from evidence-based medicine. And I've just interviewed many people with the same story. So they became frustrated that their field was basing decisions on conventional wisdom and anecdote and opinion. And they came across these ideas of evidence-based medicine. And this light bulb went on. And they sort of thought, my field should be doing this too. Like, we should be using evidence to see what really works. And one other realisation I had writing the book is I think that the evidence revolution attracts people who are a little bit rebellious, who aren't kind of afraid to speak up and speak truth to power and challenge the way things are done, and ask, like, why are we doing things this way, and is there a better way to do it? Now, the evidence revolution has been more successful in some fields than others, and I think perhaps the biggest success story outside of medicine is an international development. And here the approach rapidly swept development into economics starting in the 1990s, and it won these three researchers, Abhijit Banerjee, Esther Duflo and Michael Kramer, a Nobel Prize in 2019. And they're economists who started using randomised trials to test whether programmes actually help people living in poverty, such as offering incentives for vaccination. So do they actually have an effect? And JPAL, which is the Poverty Action Lab at MIT, run by Duflo and Banerjee, estimate that policies shaped by these trials have reached an estimated 850 million people at least. So, and I think that's been influential in driving this kind of wider embrace of evidence in guiding policy that some people today are probably part of. But in other fields I looked at, I think the evidence revolution has struggled much more. Fields such as conservation or business and management are probably two I looked at where evidence-based practice is still kind of struggling to gain traction, and it remains much more common to be using conventional wisdom or anecdotes in order to guide practice. So looking across all these fields also just made me think, like, what are the common barriers to evidence? And one common problem now, I think, is that many people have built up a lot of evidence, but they struggle to get it used by policymakers, by police, by schools, by parents. And I think there are some lessons to be learned from medicine that could perhaps help. So what we see in medicine is things we don't necessarily see in other fields. So in medicine, doctors learn about evidence as students. They use pre-prepared clinical guidelines that are based on evidence. So it's already embedded in their practice. And if they fail to use evidence and someone is harmed, then they're held to account. But those things, that the training and the accountability, aren't necessarily seen in other fields. But beyond that, the evidence movement faces bigger problems, which is the rise of an opposing force in terms of growing rejection of science and evidence and facts. And I'll just talk about that briefly at the end. So this is a story I wrote in April for Nature, suggesting that on a survey, suggesting that 70% of respondents across 16 countries believe at least one false or unproven health claim, such as risk of childhood vaccinations outweighs benefits, or paracetamol use during pregnancy causes autism. And in one UK study on trust in science published in April, 38% of respondents said there's now too much information to know what is true about science. And I think the big worry is that reliable science-based information is being drowned out by this torrent of questionable claims and misinformation on social media that will, and the wider digital world. And Deb's book, Bad Influence, is absolutely brilliant at exploring that, and I'm sure we'll discuss it in a minute. So I just want to finish by mentioning one other important message that I learnt while looking at the evidence revolution, and that's really about humility. So if you write a book about people who champion evidence, then it risks sounding kind of naively optimistic that evidence can provide all of the answers. But the lesson from the movement is around humility. I think we have to be humble about science. The evidence movement is imperfect, research is complex and changing, and it's often uncertain, it's sometimes flawed, and it's only ever really one factor in a decision. And Ian Chalmers, the pioneer of evidence that I talked about at the beginning, said to me that when he discovered evidence, he felt like he'd been given a compass to navigate through the jungle of conflicting opinions. But it is only a guide. It points us in the right direction. It tells us something about what works, but not necessarily what to do. So in medicine, doctors draw on evidence, but they also use their own expertise and, of course, the values and preferences of patients. And in policy, policymakers will hopefully draw on evidence, but they also have to consider costs and politics and public opinion and so forth. So I think most people in the evidence movement are just trying to ensure that evidence is at least part of the discussion when key decisions are being made. In other words, they are trying to keep calm and ask for the evidence. This was actually on the T-shirt of one of my evidence champions I write about in the book, who's keeping calm and asking for evidence in management. So I kind of hope the book just helps more people keep calm and ask for the evidence and feel empowered to consider evidence in their decisions. That's all I wanted to say. It might have been slightly more than 10 minutes, but thanks again for listening, and I really look forward to our discussion.
Thank you so much for that, Helen. So maybe we can start. I mean, in the book, you make such a compelling case for using evidence for informing decisions, and you make an argument for doing it more and doing it better. Can you give us some examples of where things went wrong when we don't use evidence?
Yes, absolutely. I mean, I suppose the most compelling example that I came across, and it was so compelling I put it at the front of the book, was around SIDS, so sudden infant death syndrome. So there's a very tragic story about lack of evidence in SIDS, and it goes back to this book that was written by the paediatrician Benjamin Spock, which became this huge best-selling childcare manual in the sort of 50s. And so, parents were following its advice, but he made this small change in the text in the 1958 edition. Previously, he'd been telling parents to put their babies to sleep on their backs, and he changed it and suggested that parents should put their babies to sleep on their fronts, based on some theories around, that babies might choke on their own vomit if they were lying on their backs, for example. Now, the book was so influential that parents started following the advice. Now, meanwhile, there was a sort of sinister uptick going on in the number of babies who were dying from sudden infant death syndrome, from SIDS. And there were lots of, to be fair, there were lots of ideas of what was the cause of that. And what was really missing from this was evidence from careful studies. And by about the late 60s, we saw these careful case control studies coming out, which were looking at the various factors and what might explain the rise of SIDS. And eventually, over time, as the evidence accumulated, it became clear that this advice from Spock and other paediatricians to put babies to sleep on their fronts was probably one of the most, I think I said in the book, one of the most lethal pieces of unsubstantiated advice in the history of child health. So absolutely tragic example of what happens if we don't use evidence and the damage that unsubstantiated opinions can do.
Thank you for that. Deb, you have several examples.
And where do I
within your
start? Well, just I guess in career as well. It's sort of, I mean, you can go back to some of the investigations. I think for the well, not just for the BMJ. I mean, I've sort of gone all over the place doing some really controversial investigations, not least for Newsnight. So in the book, I guess the whole book is about how evidence is interpreted on social media, and it's the we know anecdote and storytelling is what works on social media. I'd like to think it's impartial evaluation of benefits versus harms and uncertainties, how you would talk about things clinically, but we know people's stories are what sells. And I wouldn't even know where to start one specific example, but what we know from, or what we suspect, and again, there's a lack of, I couldn't go too hard in the book because at times there's an absence of evidence, and what you don't want to do as a science journalist is critique an absence of evidence and then make a claim that isn't based on evidence yourself. You don't want to debunk bad science by doing bad science yourself. It's lethal, you're hung by your own petard. But what we do know is storytelling can shape beliefs and ideas, and how much is social media a move away from this evidence-based practice and the power of storytelling and shaping our perceptions, our concerns and our expectations. And I don't know whether there's any sort of medics in the room, but we know dealing with patient expectations, this is a big part about how we interpret evidence. So I think the book is less about how evidence is being subverted, where clearly there's lots of big stories, not least around the GLP-1 drugs, the semaglutide or Ozempic, Wegovy and Mounjaro, where that goes well above and beyond what the clinical trial evidence says. But it's more that how much is belief and storytelling now taking over and more impactful than a systematic review or a meta-analysis that provides a broad evaluation of the evidence base.
Thank you. Helen, your book, the way that I read it is that this evidence revolution that you're talking about is in many ways a success story, right? Especially in medicine, as you've just alluded to as well, this is part of medical curriculum. It's part of clinical practice guidelines that all doctors are in many ways incentivized, mandated, required to follow. They're almost part of quality improvement initiatives or payment mechanisms and so on. So it's everywhere. It's really permeated. It's very much embedded into the health system. But still, EBM is far from perfect, right? And I'm thinking about your several chapters that are going beyond medicine and looking at other disciplines, other sectors. What do you think are lessons that the evidence-based medicine movement can learn from other areas?
Yeah, I mean, that's a great question. So I do also, before answering that, I mean, I'd say most other fields are kind of looking with envy at medicine. There's a bit of grass is always greener, I think, in the evidence movement, that every other discipline thinks that the other, that medicine is doing it best or whatever. I mean, I think one thing that perhaps other disciplines might be doing better is they might have a slightly more sort of pragmatic and inclusive approach to evidence. Like, I mean, one criticism of evidence-based medicine is this kind of, potential over-valorization of the randomised controlled trial, which we might come on and talk to. That it has to be that sort of perfect standard of evidence. But if you look in some other fields, I mean, let's take conservation, for example. It's really difficult to do randomised controlled trials in conservation. And actually, in the book, I tell the story of somebody who wanted to replicate the Cochrane collaboration in conservation, went out, started doing systematic reviews and just discovered there wasn't really anything to synthesise. And that's because you can't randomly allocate birds into treatment and control groups or forests or oceans. So there's a much more pragmatic approach. We're going to use quasi-experimental methods. We're going to make do with the best that we have. And also, I think maybe the conversation in somewhere like conservation has advanced a bit more about incorporating very different types of knowledge, local forms of knowledge, from communities, from indigenous communities that are really important. So I think maybe that kind of, pragmatism and inclusiveness and maybe thinking about how to, it's a really fascinating question. How do we synthesize totally different forms of evidence, like lived experience and quantitative knowledge?
Yeah, I'm sure we'll have questions about this from the audience, but you've already started talking about RCTs, so let's talk about RCTs because it's such a major theme in the book, right? It's really core to the arguments that you're making and the story that you're telling, this experimentation, this idea of experimenting and doing it in a randomized controlled trial fashion, blinding participants and so on. How did medicine come to prize RCTs the way that they've done?
Yeah, I won't bore you by going all the way back to the 1700s. So, I mean, I think... one big factor was a legal change. So because of the thalidomide disaster, when many women with morning sickness were given thalidomide, and then it turned out, of course, it had these horrific side effects. Because of that, there was a change in law in the US, such that the FDA started demanding that before approval of drugs, there had to be good evidence to show that they were not just safe, but also effective. And over time, it became expected, I think by the end of the 60s, that would be in the form of a randomised controlled trial. So it became kind of embedded in regulatory practices, and then that happened across the world. So that's one thing, because that really led to an explosion of interest in randomised trials. I mean, I think another factor is just that there were these key people who have really championed evidence in these fields, people like Chalmers, but there were sort of equivalent people, and they do often become really fired up. There's something about this method which really captures people. I mean, I had people who were cutting out every single randomized controlled trial they could find written about in the New York Times or that were published in the literature and storing them in filing cabinets and carrier bags. So there's something about it which is very compelling for people. It's this simple, amazing method. And then one final thing I'd say is, of course, the hierarchies of evidence that have come with evidence-based medicine, which kind of give in this pictorial form the idea, because often randomised controlled trials are right near the top, that it's somehow superior to all other forms of evidence. So maybe those are some of the influences.
But you also give examples where randomised controlled trials deviated from other forms of kind of study designs in terms of their results, like the hormone replacement therapy is an example that you bring up in the book.
Yes, and you might have reported on this more than me. I mean, I'm not suggesting that kind of. I think a lesson from the evidence movement is to be very cautious about putting too much weight in the randomised controlled trial. I mean, we know that they're difficult to do. They're sometimes wrong. They need to be replicated. So there's definite. Yeah, there's dangers, I think, and we just need to be aware of not putting them on a pedestal.
Yeah, thanks. And of course, you've already started talking about this, that there's this movement against medicine, against evidence across different disciplines, and especially in health. But within medicine, there's almost a reaction against randomized controlled trials. Many people are now retreating away from randomized controlled trials. They're concerned that these are very expensive, not feasible, not practical. And I was really fascinated by those examples that you bring up from other disciplines where randomized controlled trials can be done in such difficult circumstances. Can you give some examples?
Sure. I mean, one of the joys of reporting the book was finding all these highly unlikely randomized controlled trials had been done. For example, one in policing, a really famous early trial where they randomized arrest, just like a drug. So that the question was, will arresting perpetrators after a domestic violence incident reduce the number that go on to be violent again? So in this early trial, this was in Minneapolis, they were assigned to either be arrested or just to be sent away from the scene of the crime, for example, which suggested that actually arrest was effective and has influenced a lot of policies. I mean, another favourite one I have is the beer glasses randomised trial, which some of you may have actually been part of if you bought a pint in a pub in England and Wales around 1998. This is a trial that Jonathan Shepherd, big evidence champion, did, in which he wanted to test whether toughened glasses would lead to less glass accidents and injuries as compared to normal glasses, and convinced a whole load of pubs to be randomised to either have the toughened or the weakened or the regular glasses, the results were a little complicated, but sure enough did suggest that tougher glasses led to less accidents and helped convince actually the pub industry to change to toughened glasses as standard. So yes, I mean, I suppose maybe the lesson for medicine is that, I mean, they are difficult and expensive, of course they are. And I would say in those cases, like maybe the secret was having a real champion. It was having a champion who really believed that this was important to do, and was willing to drive forward until they got the approval to do the trial. But I think it was also a realisation that that there was harm going on if they didn't test it. I mean, if you think like the domestic violence one, women were potentially being harmed with the status quo, and the same with the beer glasses, people were being injured. So it was understanding that they needed the convincing evidence in order to persuade people to change, I think.
Yeah, very interesting. And of course, I fully take your point that we need to think about RCTs just like any other study design, that sometimes they go wrong in terms of the way that they're designed and conducted and reported and so on. And Deb, you've done so much reporting on some of those RCTs that have not been ideal in many ways.
No, you select the question that is going to select your patient participation. So I use this example in the book, and again it goes, and I use sort of the GLP-1 drugs, the semaglutides, the tirzepatide, the Mounjaro, Wegovy, Ozempic, sorry, slip back into generic speak, as a way of explaining to people how trials work. And, and they pick the healthiest population. When you conduct a clinical trial, because one might say in the case of these drugs, you might pick the most obese population because the weight drop is going to be better. So you can select the ideal population to show the best effect, both in terms of benefits and harms of the population. But then when you roll it out, and this is where you get the real world evidence, it doesn't look like that in clinical practice. Or you'll find these drug interactions. So for example, and this is what was interesting about social media. So a couple of years ago, Ozempic babies were trending because women found they went on one of the GLP-1s, dropped weight, and we know weight affects fertility. And then they were having babies. And then eventually the MHRA, the Medicines Healthcare Products Regulatory Agency, our regulator in the UK, issued advice and said, well, actually, if you go onto these drugs, you need to use contraception. And in the case of Mounjaro, I think 2 forms of contraception, or contraception after you've stopped it. But also how they're presented. And my old boss at the BMJ, Richard Smith, wrote a book about how medical journals are the marketing arm of pharmaceutical companies. I know, and there's a pathway, it's the playbook. You publish an RCT, phase 3 trial, before it goes to the FDA in America. You get excitement around that particular drug intervention. We know it puts pressures on the decision makers, the policy makers, to potentially approve the drug. You then press release it. The press clamours, you've got the hype, this breakthrough treatment, you see it all the time in the press. And then what you'll find in the people might only report in the abstract, so you're selective what you put in the abstract. The body might be behind, not necessarily all the case when it's a drug company funded RCT. They go for thousands. You've got the whole dynamic between medical journal world and drug companies, where medical journals make a lot of money out of print about a phase 3 trial. It makes drug companies a lot of money. And then actually you have to dig into the supplementary appendices to find out some of the detail of the trials. So for example, if you looked at the exclusion criteria of the phase 3 trials for the various GLP-1 drugs, depression, alcohol use, so there's big exclusion criteria. Or you might have the specific statistics of the BMI, the participants. So to really understand what that trial is saying, you really do have to ferret around. And then we know that is just a synthesis. And I worked with the Cochrane collaboration, funnily enough, on Tamiflu, an investigation into Tamiflu, which was an influenza drug. And 8 of the 10 trials were not published, only 2 were published. And then you realise that what you see in a journal is a synthesis of thousands of pages of evidence. And then often what is in the regulator's hands isn't in what you see in a journal. So there's all sorts of ways that the evidence and the information that we get is twisted and shaped, and selective statistics are used, or not all endpoints are reported. So there's all those, and you can spend a lifetime unpicking and unpacking all of that.
Yeah, all the more reason why we shouldn't be relying on single studies to inform decisions. And I was really, encouraged by what you report and talk about in the book about social experiments and kind of welfare program experiments in the US. The way that the people who have designed these experiments never thought of a single trial as the ultimate answer to their questions, and they always thought about generalizability and repeating it, kind of replicating the result, and then having a more kind of nuanced answer.
Yeah.
Could you talk a bit about?
I mean, maybe that speaks to what I was saying around the kind of pragmatism around evidence. I mean, often, if you trial social policy, most things don't work. I mean, I talked in the book about the 80% rule, which is just the expectation that if you trial, in fact, almost anything, probably includes health as well, 80% of things don't work. And in social policy, you often get, very small effect sizes too. So I think there is this understanding that most things fail. I mean, the one you're talking about was these sort of early trials which were done to test whether work to welfare programs, in other words, the expectation that somebody should work in order to receive welfare payments, was trialled across 8 massive randomised trials in the US. I mean, these were ahead of a lot of medics waking up. Some of these social policy experiments were very pioneering. And of course, the fact that it had been done in parallel across all these different states, and as usual, of course, it wasn't clear cut, but suggested that these things did help people get into work faster, had a big influence on US policy. Another example going on from that domestic violence one. So the initial result suggested that arrests could reduce repeat offending, but actually it was replicated, I think, 6 times. And this time the results, didn't really pan out. It was conflicting. I mean, the interesting thing around that sort of lesson was that often it's not just the evidence, it's when the evidence lands. So, the original trial, it kind of gave the message everyone wanted to hear. We need to arrest domestic violence perpetrators. Policing policy starts changing, and then these later replications come out suggesting, well, actually, it's a bit more complicated than that. And the policies were kind of, they were done. And I think that's, that happens quite a lot, right?
Yeah. Let's turn to the other theme, major theme in the book, which is evidence synthesis. I really enjoyed this theme. I teach evidence synthesis, and I see some of my former students in the room. Can you just tell us why this is so important in your view?
I mean, I've become quite an evidence synthesis geek after reporting this book, which I wasn't before. So, I mean, yes, of course, it's important because individual studies risk being wrong or poorly done. I mean, they might, be flawed, they might be biased, it might be just through chance. And so, of course, synthesis allows to bring all of the studies together and as I mentioned just now, hopefully extract a signal from the noise and also synthesize different forms of information. Again, I mentioned that before. So I think that's why it's important. And I think, too many of our, of us as science journalists, and scientists as well, are still kind of chasing after the single study, right? And that's why so often in the media it's like, red wine is good for you one week and then it's bad for you the next. But it's much better to take stock of the evidence as a whole. And that's often what's missing, I think, from the conversation.
Yeah. And this is where I was really intrigued by the standards of evidence synthesis in different disciplines and different areas. In medicine and healthcare, we tend to focus on the gold standard of reviewing the evidence, which is a systematic review and meta-analysis. But then you talk about the aluminium standard from other disciplines.
Yes.
Can you talk about this?
Yeah, I mean, I ended up thinking that there were kind of, different types of people actually when it comes to evidence synthesis. Like you've got your purists who are sort of, systematic review or die, basically. This is the thing we have to do. Nothing else matters. And then there's the pragmatists who, know that they haven't got the perfect randomised control trial, or they haven't got the time. I mean, in policy, you've got to get your synthesis to answer that urgent policy question tomorrow. So you do the best that you can in the time available. And I think I came out of it sort of thinking, well, different forms of synthesis suit different situations, basically, and depend, what type of evidence you have. So there doesn't necessarily have to be tension. And of course, it also depends on the stakes of the situation. I mean, systematic reviews are really, really important, as you were just saying in medicine, because we need to find all the unpublished trials, because that could literally show whether a drug works or doesn't, or, lives are at stake. But in conservation, there was not just conservation, but some fields, it's just not that important, actually. Like let's say you want to know if the bird box you're putting on your tree should be green or brown. We don't need an evidence synthesis to answer that question. But if it's like, I had a story in the book about this really high stakes conservation question about how to say whether it was worthwhile introducing a captive breeding program to save this highly endangered caribou population in the Rocky Mountains in Canada. And they just went above and beyond to do, it was aluminium standard, it wasn't systematic review because they didn't have systematic review type evidence, but spent months on it. So there's that as well, isn't it? It's like how important actually is the outcome or is what's at stake here.
And in medicine, in many ways, I do wonder whether the pendulum has swung a bit too far in terms of seeing systematic reviews and meta-analyses published. In some areas, we see more systematic reviews and meta-analyses than randomized controlled trials in a given area. So I'm wondering what may be driving this? What are the commercial interests in this space? And can I turn to you, Deb, about some of those?
the murky commercial interest. Well, as Helen said, RCTs can be expensive, they're hard to do. And think about the publication model, the systematic reviews and the meta-analyses, and you publish or perish. I mean, there's an incentive. What can I do? What's the research? In some ways, I think. I mean, I'm being very cynical, obviously, and that's my job to be cynical and sceptical. But in the absence of trials, let's see what's there and in some ways it might be torturing the data until it screams. Just it can a systematic review and meta-analysis, if it's based on rubbish data, you're going to have a rubbish systematic review and meta-analysis, but you can make it look more compelling because guess what, it's top of that evidence tree. So, and then you know, the sort of incentive to do it, well, let's get a publication. And having been an editor of the BMJ and starting off in an academic centre, I mean, you see all sorts of stuff that they try and get past you. And speaking of Ian Chalmers, I first came across him when I was a junior editor at the BMJ, and I didn't have a clue who he was. And obviously he didn't try and get one of those past me, but I was editing the analysis section at the time. And I was really fighting with him because he wanted a paper published. And I was really pushing back. And I was like, you can't have it. And in fact, I think the title was actually defamatory. And I was like, the lawyers won't let it pass, we'll get us sued. And I was really pushing back to him. It came to this BMJ editorial meeting. I'm from Liverpool originally, and I had a very strong Scouse accent at the time. As before I was broadcasting. I went to him, oh my God, who is this Ian Chalmers? He's a right dickhead. And everybody just fell about laughing, so I had no idea who he was. But Ian being Ian respected that sort of backwards and forwards, and it was Fiona Godley, who was the editor at the time, and emailed her, and I was nicknamed the BMJ Bulldog after that. And the cat fits. So yeah, but you know, Ian is that person who you could really spar with, and he sort of, you know, but again, you know, taught me the idea that just because it sits at the top of the evidence tree, and if you're basing it on rubbish evidence, you're going to get rubbish out.
Let's talk about AI. We didn't talk about AI just briefly. I'm just wondering how AI is changing the relationship between evidence and decision making, or how it's changing our relationship with evidence. And maybe I can turn to you both for this. Helen?
Well, I'll let Deb speak to probably how it's putting misinformation into overdrive. I mean, I think, okay, I'll say a good thing and a bad thing. I mean, the bad thing, I think, is it's putting bad science into overdrive. In terms of just, you know, I mean, the volume of fake papers, the volume of papers which have used so much AI that they're unbelievable. I mean, many journals are just talking about being completely overwhelmed at the moment with just the volume of science which is coming out, a lot of it poor quality, you know, which argues for, I mean, it makes synthesis of evidence like even more important. On the positive side, you know, being able to synthesize information from science is something AI ought to be able to do really, really well. And I think there's some really interesting and quite positive movements now to develop AI tools which can do systematic reviews or other types of evidence synthesis very efficiently. Now, I think there's a lot of hype going on at the moment, and these tools aren't there yet. But I do think, you know, that some of my evidence champions have this vision that you will be a citizen or a policymaker. You have your question, you really can push a button and much more quickly, you know, get a quality overview of the evidence. This ought to be possible. So I'm actually thinking maybe this is a really positive development that AI could contribute.
Thanks.
I think you have to look at, when we talk about AI, you always have to think about compared to what. What's our comparison? What's the alternative? So is you know, one of the LLMs or, you know, chatbots, is that better than getting your information from social media? And I don't know the answer to that. I don't think we do know the answer to that. And I think there's a lot of questions. We do know there's evidence that when there's empathy, we know there's studies that have shown that they prefer, probably quite a low bar at times, how chatbots communicate with more empathy than doctors. And, you know, that maybe no surprise there. But then when that's the case, they're more likely to believe misinformation because it's said in such an empathic way. What we don't really know yet is what a full, and I'm thinking very much at the medical end here, what a full patient journey looks like. People talk about they can diagnose. Well, diagnosis is only part of the pathway. How does someone act on that information, interpret that information? What do they do with that information for good and for bad? So I think sometimes when we talk about AI, it's what are we comparing it to? So there was that study that went around, and there was a fake paper of fake disease that went all over the place. Well, I worked at the BMJ where we created a fake disease. It was called motivational deficiency disorder, where people were too lazy to breathe. And it's classic BMJ. It was an April Fool's
Hopefully
trick.
Christmas.
It was April Fool's Day. And it was to demonstrate disease mongering, so the creation of illness, how illnesses are created. And it was invented by someone called Dr. Leth Argos. Really bad. The BMJ made them, well, there was a mistake of press releasing it, and it got picked up globally as a serious illness. And we were like, oh, obviously the British press got it, the April Fool's Day, ooh, drone. But lots of thought it was a real illness, and it was reported. So there was human error there reporting what was a fake condition. So I think some of this with AI, it's the spread and it's the speed, and it's how assertive sometimes that information is. And I used it occasionally in the book, and I put in, there's a chapter on wearables and measuring. Just because we can measure something doesn't mean we should in health. We need to know what measuring that biomarker actually does, surrogate endpoint. And ChatGPT told me this story about this doctor that put weighing scales on all the platforms across the UK, and I was like, that's a really good anecdote to talk about how we like to measure stuff. And Perplexity did the same, told me the same story, and I asked for the sources, and it gave me a New Scientist reference. Did that New Scientist reference exist? No. So I think in that spread we have to think about how we're processing it and how people are going to engage with that information and fact check and everything else. And there are questions. But again, I don't know which way this is going to go. There might be good uses, but I think it's going to be in the, checks and balances.
Thank you. When we think about kind of the future of evidence, what do you think are the biggest forces working against evidence at the moment?
Well, I think, again, I'm going to leave you to talk so we can do half and half. But I mean, the rise of misinformation and scientists kind of evidence losing influence, I think, in the public debate in terms of online, I think is really important. But I think another thing that's going on, I'm reporting at the moment on trust in science for nature. And another kind of important force that's happening, certainly in the US, when you look at these surveys of trust in science, is a political polarization that's happening. So in general, trust in science globally, most of these surveys show that trust is very high, like people trust scientists much more than journalists and politicians. But in the US, what we've seen over the last kind of 5-8 years is trust in science amongst Republicans going down, and trust in science amongst Democrats has stayed relatively high. And I think the concern is that now with the US administration, they're kind of using this potential distrust in science to basically attack the institutions. So it's like a justification kind of, we're going to destroy these institutions because they're not trustworthy. And some of that language is coming out. So that's obviously a very active live force which is working against evidence at the moment.
I think we've got to learn to adapt how we talk about evidence, and I've been asked this a lot by people from NICE or NHS England and so on and so forth. And you don't think about how evidence is presented. Don't think about the platforms, but think about how evidence and information is presented. So I was science editor of ITV News, which is far tougher to do a 2-minute, 15-second news package than it is write a piece in technical language for the BMJ. I mean, they're different skill sets, but every single story had to have a person. Now, what person did I find that communicated the evidence? Now, that was the biggest trick, and that's what social media relies on, is that anecdote. But how do institutions emulate, forget the platforms, because you're never going to compete against the algorithms, or it's going to be very hard to compete against the algorithms because they incentivize eyeballs, extremities, and money, quite frankly. I think about the social media platforms. This is what happens when you put health on platforms that are designed for entertainment and shopping, effectively. You go and buy your handbag there, your lipstick there, but then you go and get your GLP-1 medicine from there. And it's very hard to compete against that. I think the thing that I saw, and it's part of the playbook, so I talk about the playbook. We've got the old sort of, the tobacco industry playbook that we talked about. There's a social media playbook, and influencers use it, and doctor influencers use it as well. And it's hype it up, particularly in health tech space, because the regulatory framework is very, very different, and it is for pharmaceuticals. Is hype it up, have the anecdote, get people to believe it. You don't need any of the robust evidence, and I'm filming, I better not, I don't want to defame anybody. So it goes on the platform, you'll end up with a writ. But this is what's happening now. Then the other part of the playbook is you direct people to a website where you link to journal articles that are relatively meaningless, they're behind paywalls, but that gives the idea of evidence. So science exploitation is a word that has been used. And we see it with some of the podcast bros, the Andrew Hubermans, the Peter Attias, though his fall from grace has been fairly spectacular since he appeared in the Epstein files. I can say that it is, you won't get sued. It is substantiated. And they sort of use like evidence informed or science based. And it sounds authoritative. But what they don't talk about is methodology. And methodology is the sort of unsexy part of science in many, although you've made it very attractive in your book, but it's the unsexy part of science. Yeah. But the scientific language makes it science-based. I mean, it's like that old L'Oreal advert, isn't it, with Jennifer Aniston, now here's the science, and just because it's got technical language. So there's some of the challenges I think the evidence movement is struggling with, and the power, the sheer power of the anecdote, but used correctly, that powerful anecdote can be used in an incredibly informative way as well. Not that you should dismiss the anecdote, obviously, they have their place.
So how do we cut through that? As institutions, as scientists, as evidence generators, what do you recommend that we do? Helen?
I think that is the question of the current moment.
Yeah,
I feel like every panel I appear on, I mean, everybody wants that answer. We don't have the answers. We haven't got the evidence to fully answer that, right? I mean, some of it has to be that people who, I mean, you're absolutely right. I completely agree that, the anecdotes are just more compelling. The idea that it worked for me is more compelling than the data saying it didn't work when it was tested in a randomised trial of thousands of people. It just is. And so there has to be a way to kind of grapple with that. I mean, again, you can look again at medicine. So how has evidence become so embedded in medicine? Again, I mean, training is a big part of it, right? I do think I'm sure some people might ask about how we're going to kind of get evidence used better. Maybe this is slightly different to, how we deal with it in that sort of public forum. But a lot of it is quite dry things, I think, about sort of embedding it in systems so that it's automatic, right? So you don't have to think about reaching for the evidence. I mean, for doctors, it's already there. It's baked into the clinical guidelines. And again, other fields don't necessarily have that. So I think, training and systems sounds really boring, but it probably is an important part of the answer, although not the social media answer, perhaps.
I think you've split up, and again, I'm very focused on health and in particular, and the massive rise of consumer health, whether that's wearables, diagnostic tests. Pharmaceuticals are the best regulated of a lot of the health interventions at the moment, but it's what part of it is in my space, again, and this is in the book, what part of it is perhaps market failure. So we've got too many diagnostic tests that are useless on the market, but they can be hyped up on social media and create a perception that they're going to provide the answers for certain conditions. Let's say food intolerances, and food intolerances are not a defined condition necessarily. Okay, you've got lactose intolerance, but a lot of them that you find are food sensitivities. So how much of it is sort of market failure? How much of it is the way we communicate evidence in an institutional setting? How much of it is the algorithms? And I don't think, or the platform, I don't think there's one size fits all. You have to sort of break it down into chunks. So one of the doctors I interviewed in the book is a paediatric allergist. He knows in his sessions, he only can get so much into a session. But he says he does lots and lots of videos on Instagram, and he points people in the direction. Look, I haven't got time to explain everything, but here are all the videos spoken in language that I speak to you with case studies. If you've got any questions, watch those and come back to me. So it's thinking about who you're speaking to and how you present that information as much as anything else, and guiding people towards information that is in a language, in a way that they're used to and they understand, and in a format they're used to consuming. I think some of it is. But again, that's a hunch. I don't have the evidence.
It needs testing.
It needs testing.
But, I mean, there's a lot of work looking at this problem at the moment, of course.
Yeah. I'm not a fan of, I'm sceptical of pre-bunking. I will definitely say that quite strongly. I'm very sceptical about that.
Final question to you both. Are you optimistic about the role of evidence in healthcare in the future? Helen?
I am optimistic. I probably have to say that, having written a book about evidence. But I mean, I think what the evidence revolution gives you is perspective and context. I mean, you know, evidence-based medicine as a term was only introduced in 1991. It's 35 years old, okay? So, and also evidence has almost always in every field it started to be embraced in, provoked kind of opposition. So this is quite a new movement. So you could argue that the kind of pushback we're encountering today is just kind of one setback on a longer journey, you know, into evidence. And I do find it a little bit difficult to think that we're going to completely throw it out the window. Like, are we really going to say we don't care about knowledge, like knowledge from research at all in the future? I mean, okay, maybe some people want to make that argument. I just find it a bit hard to think we're going to sort of put the knowledge genie back in the bottle. So that's why I have an overall optimism, even though I absolutely acknowledge and think we have to take seriously what's going on with evidence at the moment.
I agree, and then I think the problem is when it comes up against lobby or expectation, and again I would say this because this is my background, commercial incentives or different kinds of incentives. So for example, let's take the example this week of prostate screening. Won't go into the nuts and bolts of it, but there's a very strong lobby there. Charities, celebrities, two former prime ministers arguing that we should have mass screening for prostate cancer with all the, none of the considerations of overdiagnosis and overtreatment and that. And they're difficult. Screening is such a hard concept to communicate to a lay audience, if you like. And often, you might have seen it with the Alzheimer's drugs. Again, really strong lobbies. So we can have the evidence and generate the evidence. It's what happens when that meets sort of public expectation, political forces, commercial incentives, political opportunism. That's the challenge. And then on social media, the issue again that I'm interested in is this massive rise of consumer health, where you've got people's expectation and their demands and what evidence or what medicine can and can't deliver. So it's far harder to tell somebody, let's say with an antibiotic, it's far easier to write a prescription and someone goes away happy, because we know prescriptions make people happy, than it is to say, I don't think you should have that, when social media or someone's told them they can. HRT is a case in point. You can get whatever dose pretty much of estrogen you want, even if it's not recommended by NICE or the British Menopause Society. It's very hard for a doctor sitting there saying, we're not going to repeat that script. So it's those sort of challenges, I think. You might have the evidence, but it's what's shaping expectation around it.
What's against it?
Yeah.
Thank you. Let's turn to the audience for questions. There's a question in the middle. Gentleman with the beard.
Thank you very much for such a great panel. And thank you very much, Helen, for the title of the book. Actually, I've been reading about post-truth for long years. And actually, the late Bruno Latour was the last one I read an article about post-truth, and that's the exact reverse or the contrast of what you say. Evidence versus belief. Post-truth was like belief versus evidence. So what I'm thinking is that the problem is no longer in false information, it's more that the machinery that turns media, emotions, and social fermentation into social conflict whenever the evidence is available. But that's what the whole post-truth thing was talking about. So thank you, Prof. Hussein, you asked the first part of the question that I wanted to ask, which is evidence-based institution, how can they defend truth when the real battlefield is no longer facts versus the lies, but trust versus the engineered suspicion that it sometimes gets there. So you said it's a question of the moment, and I agree on that. So maybe the second part, what happens when those institutions that's supposed to be evidence-based, they go to the other side, they start telling you paracetamol is bad for your baby's fall. So how we should react to such institutions, and what's the appropriate measures that should be taken from global level, in your perspective?
I mean, I'll probably go back actually maybe to the first bit you asked, because there was, I mean, I reported a story about people are studying this problem, right? I mean, of course, if you write about evidence, then you're always like, well, okay, well, where's the evidence to answer your question? But I reported a piece for Nature about how to speak to a vaccine skeptic. Because, you know, people have done some very careful studies of actually kind of what works. And I thought I can't promise this applies across fields, but I thought there were some really interesting lessons from that. As much as anything, we felt, our readers at Nature and myself, you know, you have these conversations in the playground and you encounter someone who has different views from you, and you're literally like, I don't know how to start speaking. So I went off to try and answer my own question. But the answer was basically, you know, don't dismiss them. People have very valid concerns and questions. Ask curious questions. You know, where is this is about vaccine hesitancy. You know, where are their concerns coming from? You know, try to offer accurate information where you can. You know, and people have sort of gone out and tested these approaches. I mean, a way to wrap that all together, that kind of compassionate response that offers accurate information, is sometimes called motivational interviewing, and actually shown that it could increase kind of vaccine uptake. So I suppose just on what are the bigger lessons there? I think it's, you know, a lot about using evidence is not about the evidence. It's quite relational in the end, you know, about building those trusted relationships that perhaps allow you to communicate the evidence rather than just going, you're wrong and here's the data.
Yeah, I mean, I was health correspondent for Newsnight during the pandemic, and so I was on air most nights a week, where evidence is changing very quickly. A lot of it's on preprints. There was massive polarisation, and any given day I was either called a COVID denier or part of a global conspiracy run by Bill Gates. You know, it was so polarised. But again, it's I sort of think of things. You've got the dyed-in-the-wool conspiracy theorists. You're not going to change their views. They are dyed in the wool. Sometimes it's monetised, it's incentivised, they might get fame, notoriety, whatever. But I think of people, I think of a similar rubric. Then you've got the sort of vaccine hesitant. Yeah. And that could be in any given area. And they're the people that have genuine concerns about rolling out a vaccine that in their view, it's only sort of what it was sort of start of 2020, end of 2021, it was a genuine question. You know, it's coming to the market very quickly. Don't dismiss. We had the conversation about masks. 1 minute there's an absence of evidence or gold standard evidence for masks. The next minute it's mask mandates. And when people react against that, and it might be from a sort of libertarian perspective or whatever their perspective is, listen to the argument, don't dismiss. And where there are genuine questions, reflect those questions. So the closure of schools, I remember asking that question in April 2020. I was called a granny killer. But I had paediatrician friends and teachers who were phoning me saying, we've lost all our vulnerable kids. We don't know where they've gone. Really worried. They don't have access to the internet. I asked that question. And they were called anti-lockdowners because they were asking genuine questions about that particular policy. So when I was on Newsnight, I banned the term anti-masker, anti-vaxxer, anti-lockdowner. Let's not put people into camps, but listen and where they do have genuine questions, let's reflect the question on the programme. And it was difficult because I got backlash constantly. But you know, could I defend no intervention doesn't have a harm, benefits, harms, uncertainties, you know, cost effectiveness, opportunity cost is normally my rubric for sort of basic reporting. I tried to stick to that as much as possible, and I could defend pretty much anything I reported. But at the core of it was what's really going on here. And a lot of it is fear. A lot of it comes down to fear. And where's people's fear coming from? And everybody was sort of scared for different reasons. And so I sort of going back to that is there are some people you're never going to reach, but there are lots of people that are just have questions, and let's not dismiss them.
So at the beginning of your presentation, you showed us this lovely timeline, starting off in 91 with evidence-based medicine, and then I can't remember the whole list, but we had evidence-based policing, evidence-based parenting, and evidence-based management. I'm wondering whether during your research and your preparation of the book, as you we look ahead into the future and continue that timeline on, what might be the fields of science? I know that obviously not all of these things are science, is management a science debate, but in what fields or areas might evidence-based practice be coming? And as a corollary of that, I suppose, in what fields should evidence-based practice ideally emerge that perhaps is not evidence-based enough? So I guess that's two parts.
So I would say the field where I want it to come, and I touched on a bit at the end of the book, is around parenting. I mean, I have a personal interest in this, but there is for something which so many people do, there is no Cochrane equivalent of, you know, best practices, evidence-based practices in parenting, even though there is a lot of evidence. There are I mean, I just found it so extraordinary that I could have had 3 children and have just been following all this conventional wisdom and advice the whole time, when actually there are these, like, you know, very strong tested and randomised trials, approaches to parenting, which I wish I had known about. I mean, a lot of the principles of these are, you know, very commonly shared. But I do think that's, and there are champions of that. I mean, I met up with one for lunch last week who's trying to get a kind of global movement going in evidence-based parenting. And I'm like, that sounds fantastic to me. So that one I think is emerging. I mean, basically any field where, which is rapidly moving, I mean, is one where we don't have the evidence yet and will hopefully embrace in the future. AI regulation. I mean, I think there's a really obviously interesting debate going on at the moment about social media and, you know, harm for adolescents, right? So Australia has introduced a policy to ban teenagers from social media. We don't know whether that's the right thing to do. And so, but scientists are studying that, which I think is really interesting. It's interesting to start to see some of the results coming out. So they're building, I mean, that's what you have to do in some situations. You can't wait. You have to introduce the policy and then study it as you go along and hopefully collect the evidence which other people can learn from. So I think you can find those areas by looking at where maybe science or policy is quite clearly advancing or taking big leaps. Those are the ones where we haven't got the evidence yet.
Did anyone else add something? This question.
Thank you both. I want to. I'm coming from a dental sector in this for this particular issue, where evidence is largely based on what's been asked, because if questions have been asked, there's a gap, and therefore the influences on what gets asked and then what gets explored is, I think, very important. And there are some examples in dentistry of what's going on, not least the banning of amalgam in 3 or 4 years if it goes ahead. But in that situation, what has arisen there in part is because changes in university funding, where the promotion of research is heavily dependent on acquiring funds from various sources, where industry is particularly keen to promote various products, so the questions get asked. Do you think that the way that university funding is occurring now, because that's where the major source for research is going to come to influence this, do you think university funding and the policies taken in that are a problem, or is that another question that needs to be?
Yeah, I mean, I think it's part of the problem, because also you tend to get, you know, where there's some initial evidence, then people ask more questions. And so, I mean, there's this really interesting approach in some fields called evidence gap maps. Have you ever seen these? Where, you know, you basically map with the size of a circle where the evidence is. And it's just fascinating for exposing these huge blank spots of really important questions when nobody is asking. And of course, that's really where the research should go, if those are important questions. So yes, I mean, I completely agree that's part of the problem. And that's why, you know, in some cases around policy or other fields, there's also this really sort of emphasis on, well, we need to ask the users. I mean, we need to ask the policymakers what the questions are that they need answering, right? Rather than just do what scientists want to do. And similarly, you know, the questions which patients want to be answered, right? That should be really part of the conversation. Again, rather than just what pharma companies want to be studied or scientists think will win them the funding.
You see that particularly in women's health. And if you think about the NIH, National Institute of Health, the biggest, I think, funder of health research in the world, didn't allow women into clinical trials until 1993. That was when Jurassic Park was in, you know, the cinemas. And so there's a massive gap in women's health. And then what's happened is that then there's exploitation. So you have a big femtech sector that have stepped in to offer interventions that help empower women, lack an evidence base. Now, I don't think empowering women is offering them interventions that lack an evidence base or are exploitative. So and that's a sort of, and where there is a gap, potentially there's always someone potentially to fill it if there is and that's when the commercial incentives really kick in. So it really is, I think, in some ways up to I guess, government and the public, what questions do we want asking? And there is a massive push and push back on women's health. But the gap is filled by, not all the time, but sometimes nefarious players. And you see that across healthcare, really, I think. And if you're in dentistry, I'm sure, you know, seeing similar. I know less about dentistry, but yeah.
Yeah, great, thank you. I study ageing, age-friendly cities to be specific, so I'm a social gerontologist. And it's interesting that you mention limitations because lots of randomised control trials have a upper age limit, yet they medicate older people. But that's not what I want to ask about. I'm more interested in qualitative research and qualitative evidence because I do quite a lot of mixed methods research. So lots of my quantitative studies have first started with the qualitative study and asking people what they think, like you've both mentioned. But I wonder about anything you've uncovered around how you use qualitative evidence or, you know, prove the rigour of qualitative studies, because you can. But, you know, a lot of the talk is about quantitative evidence. So I wondered if you could talk a bit about qualitative evidence.
I mean, it sounds like you probably know more about the rigour of qualitative evidence than I do. I mean, I do think it was quite interesting. I've looked more perhaps at how, again, you synthesize these different forms of evidence. And so, I mean, I think mixed method syntheses are really interesting of trying to sort of bring those in, right? And again, that might be a lesson which isn't transferring necessarily between fields. So I'm not sure I have the methodology expertise to perfectly answer your question, apart from
I'll just go back just to say that I think you've got a lot of expertise in it because a lot of qualitative study is about storytelling. And, you know, I've read, you know, the Life Project and it's a fantastic story, you know, so I think it's a challenge really to quantitative researchers, to medical researchers, to, you know, look to qualitative research and kind of see what it can add to what you're doing.
Yes, I completely agree with you, and that's sort of what I was getting at before, of saying that's perhaps a lesson which can be learnt by medicine from other fields. I mean, I think it's a bit less evidence snobbery, isn't it? Of like, I mean, I certainly came out of this whole reporting exercise just being much more open, I think, to because I also came from a quantitative, background, of just being more open to other forms of knowledge and trying to understand them. And they're also important and valid and all add something to our understanding. And maybe that's a lesson that a lot of people can learn, is to get out of their evidence camps and be open to these other forms of knowledge.
I think you've just made me, as a journalist, I do mixed method storytelling, maybe,
Yeah.
and I hadn't even thought about that before, so it's really interesting. And I was on the BMJ where they decided they weren't going to publish qualitative research anymore. It was just, we're not going to do it. And there was incredible, understandable backlash, but that is where the storytelling comes in, understanding where people are coming from, how they're interpreting, how evidence is being used that from quantitative research. And I think that perhaps, certainly in medicine, there's perhaps been a snobbery, not helped by the likes of my old employer, I was there at the time, saying they didn't ban it, but they said they weren't going to publish it anymore.
Sorry to hop the microphone, but because you can tell a good story like you both have tonight, or you can tell a bad story like the ones that get, throw rampage on social media or whatever. So maybe we all need to be telling better stories.
I do think that, but I also worry a bit that we just go, oh, well, the answer to this, to what you've been talking about online is, if only the scientists could tell a better story. And it's just not, it's not going to be as simple as that. I just think
competing against the algorithms.
You not only have to tell a story, but you have to tell one which makes people really angry and emotional. And it data doesn't do that very well.
It incentivises the wrong thing. You might happen upon something, and I think institutions get sort of obsessed a bit about what do we do on social media. And my view is be platform agnostic. What people need. Algorithm training needs that. People need to understand how the algorithms work. Whatever happens with social media bans, people need to understand the algorithms, and the tech companies need to do better there, and give people the power to curate their own algorithms better than they do now. But it's guiding people, I think, giving information, and you do mixed methods, storytelling, guiding people to sources of information. If the alternative's the NHS website, not surprising people are going to go to TikTok or Instagram if the alternative is and I didn't use it in the book, but I interviewed a guy that had written a book about biases, and social media plays into all sorts of biases, confirmation bias, all that kind of stuff. And he said to me, well, I don't know why people even look at social media for their health information when there's perfectly good sort of NHS website. And I thought, you don't get people, do you? Fundamentally, stick to the finance. But I do think, sorry, I'm probably not answering your question, but it's less about the platforms, it's more about how we tell, and which is where your research is really important, the mixed methods, how we tell the story of information.
Excellent. I think that brings us to the end of the event. Thank you both for this really fascinating conversation. Thank you for writing the book and sharing it with us.
Thank you for having me.
So books will be available for purchase outside, and we have drinks, I think, outside as well. So please continue the conversation there. Thanks again for joining us.